Hi, Chris Good here, and this is a talk on modes of drug action for Psych 2050. Most drugs come from plants, or they're chemically derived from plants. So we have an example here of ephedra, which is a Chinese herb, also known as ma huang, and it's from this plant that we can derive a drug that's called ephedrine. Which formed the basis for a synthetic version of it later on that was amphetamine. So a lot of drugs originally started as chemical compounds that are generated by plants, often to keep people or animals from eating them. We name drugs in several different ways. So we can talk about the chemical name for a drug, which is the complete formal chemical description of the molecule, the drug molecule. For example, there's N'2,5-dimethylamino-methyl-2-furyl-methylsulfanyl ethyl N-methyl 2-nitroethene 1,1-diamine. The generic name for this, much easier to have a shorter name for that, so the generic name is that official legal name that's listed, at least in the United States, that's the official name listed in the U.S. Pharmacopoeia. For example, that chemical compound is called ranitidine. It's much shorter to say ranitidine than to say the chemical name. Now, ranitidine is sold under the brand name Zantac. It was invented by a pharmaceutical company, or isolated and tested by a pharmaceutical company, and they named it Zantac, and that's their trademark version of this chemical compound that has the generic name ranitidine. Once you trademark a compound, you can patent it, and the patent lasts 20 years. Zantac is out of patent now, and so you can buy ranitidine under different brand names. There's a generic version of it available, as well as other people are able to use that same name. So another concept from this chapter in your textbook is the idea that in addition to the actual direct effects of drug molecules, there may be non-specific drug effects as well that don't really have anything to do with the interaction of the molecule with your body's chemistry, but have more to do with your expectations about the effects of the drug, the user's unique background, your perceptions, even the setting in which the drug is used. Specific effects, on the other hand, depend on the concentration of the chemical, the location of the chemical, and its interaction with your body chemistry. One type of non-specific drug effect we refer to as a placebo effect. So placebo effects are the effects of an inactive chemical that the user believes to be a drug, and placebo effects can be very, very powerful, particularly in treating pain and also psychological depression. So you can actually get non-specific effects of even placebos, inert, inactive chemicals that have profound effects on pain, as well as psychological conditions like depression. So because there are non-specific effects, we often need to test drugs in a double-blind method. That's when the person taking the drug doesn't know whether they're taking a drug or a placebo in an experimental test. But also the researcher who's interacting directly with the participant can't know what they're taking either, so as not to treat them differently. All right. One other concept from this chapter is the idea of a dose-response curve. And this just shows you that people respond differently to different drugs. So if you see here on the slowed reaction time sort of S-curve on the left-hand side of this graph, you can see that for alcohol, at a very, very low dose of alcohol, there's no effect, but as you increase the dose, a greater and greater percentage of individuals exhibit slowed reaction time. So right at the point where this inverts and starts changing direction, it's about 50%. At higher doses, pretty much everybody's reaction time is slowed, but only a few people demonstrate that profound lack of coordination that's called ataxia. And at even higher doses of alcohol, where everyone pretty much exhibits ataxia, a smaller percentage are exhibiting symptoms of coma. So the size of the response is related to the amount of the drug that's administered. And different effects have different response thresholds, as shown in the graph. One other concept I want to emphasize is the idea of effective and lethal dosages. So the effective dose of a drug is the dose that produces an effect in some percentage of test subjects. We typically use 50% of the test subjects as a benchmark. So you can talk about the ED50, which is the effective dose for 50% of the usually animal subjects in a drug test. So it's the dose at which 50% of the animal subjects or the test subjects achieve effect, whatever the effect is supposed to be. That's where you see the effect of 50%. The lethal dose is the dose of a drug that has a lethal effect in some percentage of test subjects. So here we generally do work with non-human animal subjects in order to establish what is the lethal dose of the drug. So we can talk about the lethal dose for any proportion, but is typically benchmarked at 50%. So the LD50, you probably know, is the lethal dose at which, it's the dose at which 50% of the animal subjects in a drug test die. So we could take a ratio of one of these to the other, so and calculate something called the therapeutic index, which is the ratio of the lethal dose to the effective dose. So pause here and think for a moment about whether you would want a high therapeutic index or a low therapeutic index. I'll wait while you pause. Okay, if you're back, if your therapeutic index is high, it means that the LD50, the lethal dose, is very, very high, and the effective dose is very, very low. And that's the ideal situation. So you would want a drug where, in order to kill 50% of test subjects, you would want an extremely high dose. But you would want, by comparison, an effective dose that is much, much lower than that. So therapeutic index is designed to give you a number that is high when the drugs are safer, although nothing is safe, and very, very low, right, close to 1, or closer to 1 when when it's a dangerous drug, when the LD50 is smaller proportionate to the effective dose. So therapeutic index should be high. Finally, we can distinguish between or among potency, toxicity, and the safety margin. So the potency of a drug really has to do with the dose, right? The amount of the drug that's required to produce a given effect. A potent drug, a very potent drug, only requires a small amount to produce a particular effect. That's different from toxicity. That's the capability of a drug to do damage or cause adverse side effects, which is different from the safety margin. Safety margin is the difference between the dose that produces the desired effect and the lowest dose that produces an unacceptable toxic reaction. So you want drugs with a very, very large safety margin, a big difference between the dose that gives the desired effect and the dose that produces unwanted side effects. This diagram we reviewed in class a little bit, and it simply shows you how drugs are distributed through the body in the bloodstream. There are many routes to the bloodstream, including intramuscular injection, subcutaneous injection, intravenous injection. All of those injection routes go into the venous blood system. Oral ingestion of a drug results in metabolism by the liver before going into the venous system. Insufflation also is delivered eventually to the rest of the bloodstream through the venous system. And finally, inhalation kind of skips that whole side of the circulatory system and goes directly into the lungs. You'll see in the diagram that means that technically to get a drug to your brain, that's the shortest distance, although intravenous injection allows you to deliver almost exactly as rapidly, almost over as short a distance, much, much higher concentrations of a drug very rapidly. All right. One important concept in this chapter is the idea of the blood-brain barrier. Blood vessels in the brain are surrounded by very tight junctions of cells that protect the brain from toxic things, including drugs that are circulating in the blood supply. And there's some drugs that really can't cross the blood-brain barrier. These, when they act on the central nervous system, are acting outside of the brain, on the peripheral nervous system. only lipid-soluble substances can leave those very, very tightly surrounded capillaries in the brain. And many of those brain capillaries, that blood-brain barrier, is created by glial cells that also increase the difficulty for those compounds to leave the capillaries. There are some systems that involve active transport where proteins shepherd molecules outside of from the blood-brain barrier into the brain, but it's important to realize that head trauma and certain infections, inflammation, can impair that blood-brain barrier and result in a greater quantity of a drug getting into the brain than otherwise would have been. All right. Drugs can interact with each other, sometimes in unpredictable ways. For example, combining depressants can have additive effects in sometimes nonlinear ways. They can cause respiratory depression. So sedative drugs plus alcohol can be dangerous to mix together because of their additive effects. Stimulants and antidepressants, which also can have a stimulant effect, can lead to overexcitement or high blood pressure or heart arrhythmia. Stimulants and depressants you would think would cancel each other out, but they don't necessarily, because depressants relieve inhibition initially. And so if you're taking a stimulant and relieving inhibition that otherwise would have been there, that can lead to explosive and sometimes dangerous and unpredictable behaviors. Finally, I should mention there's a substance called cocaethylene that is produced when cocaine is mixed with alcohol. Many people use these drugs simultaneously without knowing that this toxic substance results when combining those drugs. It has to do with the metabolism of both of these. All right. The drug ceases to have an effect when it's excreted from the body. Sometimes it's been unmodified, but many times drugs are chemically metabolized. So they're metabolized often in the liver and usually by active metabolism using enzyme proteins. There's a whole family of liver enzymes called cytochrome P450 or CYP450, but there are lots of other families of liver enzymes. This collection of enzymes is actually quite large. It's a very large liver enzyme family, and sometimes that enzyme may be busy metabolizing something else. There are drugs that share the same metabolic pathway, and so in order to break down one of them, it requires this cytochrome P450 family type of enzyme. And if you're using them up, metabolizing that first drug, there might be not enough left to break down the second drug. And so you might have greater concentrations of the drug than you otherwise would have were it, without that first drug. Sometimes the first metabolite of a drug is no longer psychoactive, but sometimes it is. So we talked about an example in class where the first metabolite of cocaine is benzoyl-cognine, which has a similar mode of action as cocaine does. And so until that first metabolite is further broken down into an inactive form, you're still going to experience the stimulant effects of the initial use of that drug. Finally, eventually drugs get excreted and they're no longer in your body anymore. So we can talk about half-life, which is the time that it takes for a drug to be metabolized to half of its original concentration. So we talked in class about cocaine having a half-life of 40 minutes. So if you use 10 milligrams of cocaine, right, 40 minutes later, half of that will remain. You'll have 5 milligrams. But it's not the case that that 5 milligrams is gone after another 40 minutes, but that half of that 5 milligrams is gone. So at 80 minutes, it's half of the 5 milligrams. It's 2.5. After another 40 minutes, it'll be half of that, and so on and so on and so on. So that's drug half-life. Finally, we can differentiate between tolerance of a drug that's due to sensitivity of cells that respond to the drug. We can talk about sensitivity of the metabolic system that may ramp up with repeated use of a drug. So you may actually produce more liver enzymes in anticipation of having more drug on board, and so you can tolerate a greater amount of the drug. You can also adjust behavioral tolerance. So the drug might actually be unaffected by changes in metabolism, or there may be no changes in metabolism, but drug users learn to compensate for nervous system impairment. So you may not experience as great an effect on behavior just because you're anticipating the effects of the drug and compensating for them. All right, that's it. Please email if you have any questions, and we'll see you in class.